Yeah, so it's my pleasure to introduce David Lin. David J. Lin, MD, is a critical care neurologist and neurorehabilitation specialist at Massachusetts General Hospital and an assistant professor of neurology at Harvard Medical School. In his clinical practice, Dr. Lin cares for patients with acute neurologic injuries, including stroke, brain hemorrhage, and traumatic brain and spinal cord injury in the MGH Neurosciences Critical Care Unit. He also directs the MGH Neuro Recovery Clinic, the mission of which is to provide longitudinal rehabilitation-focused care for patients recovering from acute neurologic injuries. In his research program, Dr. Lin directs the Laboratory for Translational Recovery, an interdisciplinary group of clinicians, scientists, and engineers working together to improve neurorehabilitation for patients recovering from stroke by understanding systems neuroscience mechanisms of motor function and recovery. Thanks so much, David, and we're excited to hear your talk.
Thanks so much. I just want to confirm you guys can see my screen and presenter mode.
Yes, we can.
Thank you. First, just wanted to thank the co-chairs of the symposium for putting together a really thoughtful session. I've really enjoyed it so far. So I'm a neurologist at Mass General and Harvard. I also see patients at the Providence VA. And so my role here is really to provide some clinical perspectives on stroke, which I hope will be helpful for everyone in the audience. These are my financial disclosures, none of which are really pertinent to what I'm going to be talking about today. So, the objectives for the next about 10 minutes are to really talk about stroke robotics within the stroke care continuum, to talk about clinical trials and a few of the challenges that I see toward clinical translation. And then lastly, to provide a few perspectives on how the field moves forward. All right, so this is a few years ago. This is the MGH helipad. This is a helicopter this is a helicopter landing on the helipad. This is me now a few years ago as a stroke fellow. This is a patient with acute stroke who's being brought to MGH for acute stroke therapy. This patient had received a clot busting medication at an outside hospital and was being transferred to MGH for endovascular therapy. You'll see here that the middle cerebral artery on the right is fully occluded. There's a clot right here. This patient went down to the OR straight from the helipad and had the clot retrieved. So the last 20 years really has been a pivotal time for acute stroke. From the advent of TPA, the clot busting medication that I spoke about in the mid-1990s, to really in the last few years, just in the last few years, which really happened in the 2015 to 2018 time, there was a slew of trials that were positive in the area of endovascular therapy. But the truth is that it remains that for acute stroke, only 1 in 20 patients are treated in time for acute stroke therapy. And as a result of that, stroke is a leading cause of adult disability. And as this crowd knows, in spite of rehabilitation, a significant amount of stroke patients remain severely disabled. And upper extremity motor impairment is a large source of disability for people who have had strokes. And really, in contrast to acute stroke therapy, our new treatments for stroke rehabilitation really remain limited. So when patients come to Mass General, their first question in acute stroke is really, how will I recover? And their second question is that really goes along with that is, well, what can I do now in order to maximize my recovery? And I would say, as clinicians and neurologists, our ability to answer these questions are still so far pretty limited. We've made a ton of progress in research in the last many years, but really our ability to provide answers to these questions and hand in hand really new therapies to help people recover is pretty limited. And this is a really complex problem, and I think that's really what I want everybody to take away from my talk today, is that stroke motor rehabilitation is probably one of the most complex motor control problems that exist in the world today. We hosted a workshop in 2020 in which we brought together a group of neurologists and rehab folks as well as patients. We all met at the Boston Copley, and we talked about what are the challenges that face us today. And really, if you look at this slide, what you'll see is that a lot of the challenges that face stroke recovery are really about health systems. There's nothing really about science here. This is all about that patients with stroke, they suffer from poor access to care, they suffer from poor insurance, et cetera. And I think one of the difficulties of doing research in this space is that the clinical reality of caring for patients who have acute and chronic strokes makes it really difficult to provide adequate research for them. And so at Mass General, in the last now 10 years, we designed a study in which we're tracking stroke patients over time. We've now recruited about 200 patients in the study. We follow them from the acute stroke setting and over time. And we've really learned a lot from doing this. And I'll talk a little bit about what we've learned in the next couple slides. Really what we wanted to do was understand from the acute stroke setting who recovers really well, who doesn't recover at all, and who recovers a little bit. Because I think as neurologists, a lot of us firmly believe that we have to sort of understand what are the neurologic factors that contribute to this before we can really create new therapies to make people better. All right, so a few perspectives about upper extremity robotics. So at a really high level, as this crowd knows, there are upper extremity robotics for assistance, and I equate this to like a pair of eyeglasses that you wear. When you wear it, then you see better. There's also upper extremity robotics that are provided for rehabilitation, meaning you go to a therapist, you use the device in the therapy sessions, and by using the device, your vision gets better. Now, these obviously interact, but I think keeping these two classes in our heads clear is really important. For stroke, this layers onto a complex biology. So in acute stroke, which is all shown here, there are changes that happen in the minutes after stroke, at the cellular level, at the circuit level, at the behavioral level. For stroke recovery, there's also a really complex biology that I'm obviously not going to get into in the next few minutes. But I'll suffice it to say that this is a biology that plays out from the first hours after stroke to years after stroke. And as a neurologist and neuroscientist, I firmly believe that the technologies that we build really have to interplay with this biology. When many of us think about stroke rehabilitation, this is likely the first figure that comes to our mind. This is a study that was published in the mid-1990s in Science, in which they induced strokes in monkeys, and they showed that there are maps in the motor cortex of these monkeys that change. So the parts of the motor cortex that control the fingers versus the wrist versus the proximal arm change after stroke. And what the same group went on to show is that if you give rehabilitation, you can actually change those maps back. So if you give rehabilitation to the fingers, the part of the motor cortex that got smaller after stroke would get bigger again. At a systems neuroscience level, this also plays out. So in healthy people, when you think to move your right arm, your left motor cortex lights up. In stroke patients, the trend is that if you have right arm impairments, the bold signal in fMRI will be more bilateral. And that's more true the more severely impaired you are. Now, I'll talk a little bit more about this in subsequent slides. So I'm just going to briefly highlight two clinical trials in stroke robotics, and I'll talk about why I think they failed. But these are the largest two clinical trials that have happened in stroke robotics today. So the first was a New England Journal paper that was published in 2010. This was a study that was run at the Providence VA, actually, where I work. And this was a large coordinated effort that was built on decades of fundamental research. It was built on the MIT Manus arm. This was a robot that was built at MIT in the 1980s, 1990s by Neville Hogan's group. The whole idea is basically that that normal arm movement, the speed profile is built on a sine curve. And the basic idea is that if you restore a lot of repetitions of normal arm movement in stroke survivors, that you could make patients better. So just briefly, the video shows the patient. It's a planar robot. If you can't reach to a radiolate target, basically the robot will make the movement will make the movement toward a target for you. And the long of the short of this trial is basically that robot care, which provided a lot of repetitions of the arm, was better than usual care, but was not better than the same amount of doses as provided by a therapist. That's shown here. This was echoed in a larger trial that was done. Also, a really large trial took place in the UK. Over 700 patients enrolled, took place in 2019 in Lancet. And this trial also showed the same thing, also used the MIT Manus arm, millions of dollars spent, but again, showed that robot-assisted training was not better than actually, in this case, either usual care or enhanced upper limb therapy. Let me just ask the chairs one quick question. How much time do I have left? Because I'm not really keeping track. Do I have about 5 minutes or?
We're running a little behind, but I think we have a little bit of lead time. So I think feel free to keep going. 5 minutes, yes.
Okay, if I run to like 2 minutes, just give me a thumbs up or something, and I'll stop.
Thanks.
Okay, so I'll talk in the next few minutes about why I think these trials failed, and why I think unless we do some really deep work, trials for many years to come will fail. So the first is about outcome measures. This is work from our group at Mass General that built off the natural history study. So these are two really simple outcome measures that many people will be familiar with. You ask patients to squeeze a dynamometer or to move blocks. This task takes about a minute, right? You ask a stroke patient to move a set of blocks from one compartment to the other with their arm and hand. This one, you just ask them to squeeze. And so our hypothesis was that, these are two simple motor tasks, but that this is going to be harder for patients because it takes a minute of sustained attention. They have to be cognitively there for a minute to be able to move these blocks over this divider. So we took about 50 stroke patients. We followed them over the first 3 months. And the first thing we showed is that both for the affected arm, the contralesional arm, and the unaffected arm, at all 3 time points, the box and block score after a Z-score, so you match them, was worse than the grip strength score. So that's interesting, because you wouldn't necessarily expect that after you Z-score 2 tests. And then we showed that the more cognitively impaired people were, especially in the acute stroke setting, the more they performed worse on the box and blocks test than the grip strength test. Okay. And then, to make a long story short, we mapped their performance onto injury patterns in the brain with stroke. And we showed that while grip strength maps onto places in the brain that are important for motor function, this is the primary motor cortex, this is the corticospinal tract, box and blocks maps onto a much wider area of brain injury that really maps onto areas of the brain that are important for cognition, like the insula, et cetera. And so one key area that I think is a future challenge is that we really have to think hard about the outcome measures that we use in stroke trials, because even very simple outcome measures that we think they're simple are testing much more than the motor system itself. All right, the second story, and then I'll move on to future directions, is really that the phenotype of stroke recovery is quite complex. So people have studied this for a long time, but basically the phenotype over time is that stroke patients initially, if you're very severe, you're flaccid and paralyzed, reflexes return, you move in synergy, meaning you co-contract, you move out of synergy and you get to normal movements. Now, there's a lot of debate about whether this phenotype is really true for all stroke patients, but in general, this generally holds up. But to layer onto that, the stroke motor is not just weakness. There's loss of coordination, there's synergies, there's increasing resting tone, there's spasticity, there's clonus. And there's a tendency in stroke trials to sort of lump this all together and call it one thing, like the Fugelmeyer. It turns out that that's likely overly complex. And I'll just say one quick thing about why we think that is. So we took 141 stroke patients at Mass General, and the first thing we did is we just did the Fugelmeyer on them. But as people know, if you look at the Fugelmeyer scale, it's a scale from 0 to 66. There's many different items in them. There are some items that involve the arm and elbow, other items that involve the hand. And we actually showed that, first of all, the normal pattern that you see where the arm and elbow are less impaired than the hand is true for the orange people because their arm and elbow is better than their hand, but is not true for the blue people. So there's a lot of people who actually don't obey this rule of proximal greater than distal. And then we showed that maps onto outcomes, that like whether you're more proximal or you're more distal, that actually maps onto how you're doing, both in the acute stroke setting and how you do over time. And then we showed that that actually maps onto patterns of neuroanatomy. So arm and hand maps onto really primary motor cortex, while proximal stuff maps onto deep white matter. Okay, I'm going to finish by talking about perspectives on directions forward. So stroke robotics is a really promising area, but it really fits into this matrix of different therapies that are available for stroke patients, some that are ready for clinical application that are being used today, others that are in preclinical development, and there's a whole span of clinical translation. I would say that for stroke robotics, I think that the missing link is that fundamentally, as a neuroscience and neurology field, we don't really understand relationships between stroke lesions, motor network effects, and behavior. And I think in order to push stroke robotics forward, we really have to get better at this link. It's complex, really complex. And so I think, along with the themes of the workshop today, interdisciplinary collaborations are going to be fundamental. And so in Boston, locally, in our lab, we collaborate closely with Connor's lab at Harvard, with people at Northeastern, neuroscientists at Brown, at the MGH-IHP, with therapists. So just to conclude, I'll say a few concluding points, which is that stroke robotic technologies are a unique opportunity. But clinical trials, large-scale clinical trials to date have been probably oversimplistic. And I think in order to advance this field, we really need better brain-behavior relationships. And this really applies to informing all steps of fundamental engineering from really the beginning to outcome measures. And I think that this will require coordinated efforts between clinicians and scientists. This is our lab at Mass General. There are a lot of people who have contributed to this work. So thank you. Take any questions.
Thank you so much, David, especially for providing such thorough neurological background, because I think the majority of people in the audience are primarily engineers who may not have had such thorough presentation before. With that, I'm going to ask a question that's maybe a little bit more opinion-based, but I wanted to thank you for talking about the study comparing sort of results from grip force and the box and blocks task. And so I wanted to ask, how would you encourage engineers to design studies to evaluate the function of the devices that they're building? Do you think that, going back to Drew's talk a little bit, engineers should start by focusing on like a specific task, so something more like improving grip force, or improving like overall task performance, so something similar to a box and blocks task that takes more than just motor performance into account?
Yeah, great question. Even the fact that you're asking the question like that, I think is fantastic. I think that the outcome measures of the clinical trial or the experiment, no matter how big or how small, just needs to be matched with the hypothesis of the experiment or the trial. So if the assistive or rehabilitative, if the technology is working at the level of motor impairment of grasp, then the first thing I would say is think about a measure that measures motor impairment of grasp, and don't try to jump to the whole arm, let alone functional disability, because you're likely tackling too many things. And I think there's a tendency to do that in the field, is to say, well, I've created this thing that I think will do this. Let me jump to like curing the world. And I think that I think that it's just important to be linear about it while keeping the eye on the goal. So I think to answer the question, I think matching the outcome measure to the hypothesis of the study is important.
Great. Thanks so much, David. And we look forward to asking you a lot more questions on the panel and getting your insight. For the sake of time, we're going to move to the next speaker. But again, I encourage the audience to submit questions through the Google Sheet that we have linked to the website, or ask them later in the panel discussion.